Bismillahirrahmanirrahim. So now we are starting the central nervous system. So in the central nervous system, first syndrome is Fragile X syndrome, most common inherited form of intellectual disability. It is an X-linked disorder, trinucleotide repeat, that is CGG repeat expansion, and that will result in hypermethylation of FMR1 gene. So there is a trinucleotide repeat expansion which is CGG, and that will result in hypermethylation of FMR1. The C is prominent. So there's a mnemonic that's CGG. So in these people, there is a prominent chain. So you can remember it by C. And GG means giant gonads after age of 8 years. So there will be a prominent chain and there will be giant gonads, as you can see, a prominent chain and macroorchidism. So other features include long face, protruding eyes, prominent forehead, speech and motor delay, begins walking and talking around age of 20 months. So there is a speech and motor delay associated with ADHD and autism. So this is a characteristic patient of Fragile X syndrome. There are neurobehavioral problems, prominent forehead, large ears, narrow and long face, and prominent chin will be present along with macroorchidism. Then we have common causes of intellectual disability. The first one is fetal alcohol syndrome. The key finding in the fetal alcohol syndrome are smooth philtrum, thin vermilion border, small palpebral fissures, and microcephaly. These things will be seen, as you can see in this picture of the fetal alcohol syndrome. I have to zoom it in a bit. So here you can see fetal alcohol syndrome. The child is having microcephaly. Along with that, there are railroad track ears. I think there are some railroad tracks formed like that. Okay, so railroad track ears. Then we have epicanthal folds, flat midface, smooth philtrum, underdeveloped jaw, thin vermilion border, upturned nose, low nasal bridge, and small palpebral fissures. Okay, so these are conditions of fetal alcohol syndrome, and fetal alcohol syndrome is one of the conditions which is associated with the intellectual disability in children. The second syndrome is just give me that. Yeah, second syndrome is Down syndrome. So in these people, in these patients with Down syndrome, there's a flat facial profile. Then secondly, there are slanted palpebral fissures, small and low set ears. The body will show excessive skin at nape of the neck, single transverse palmar crease, clinodactyly, and large space between the first two toes. Standard toe deformity will be seen in the children with the Down syndrome. If I could zoom it in now. So here you can see that the features in Down syndrome are there will be epicanthal folds, up slanting palpebral fissures, like they will be slanting upwards and upwards like that. Then the second thing is there will be low set ears, flat facial profile, low set ears, small ears, flat facial profile, short neck with the excessive skin. There will be central toe deformity, single transverse palmar crease like this, and then there is hypoplastic incurved fifth finger, and brush field spots are also present. The next disease is what is this? Just let me see. I think this is clinodactyly or something. This is clinodactyly. That there is, yeah, this is clinodactyly. What happens in clinodactyly? There is delta phalanx, triangular shaped growth plate that causes an incurved fifth digit. Then the Fragile X syndrome, we have talked about that before. So in Fragile X syndrome, the problem is that the long narrow face, prominent forehead and chin, large ears, and macrocephaly will be present. Body will have macroorchidism. So common causes of intellectual disability, again the same three syndromes are present. So for the Down syndrome, the dysmorphic features include upslanting palpebral fissures, flat nasal bridge, epicanthal folds, and single palmar crease. Comorbid conditions include heart diseases like AV, canal defect, short stature, obesity, and hearing loss. Fragile X syndrome, the children will have long face with a prominent chin and forehead, large protruding ears, macroorchidism, and macrocephaly. Comorbid conditions include self-injurious behavior like hand biting, anxiety, autistic behaviors, and tall stature. Fetal alcohol syndrome includes smooth philtrum, thin vermilion border, small palpebral fissure, and comorbid conditions have seizures and growth restriction. Frederick ataxia. So this is a classic picture of rhetoric ataxia, in which we can have hypertrophic cardiomyopathy and kyphoscoliosis, high arches which are pes cavus, loss of proprioception and vibration sensation because of the involvement of dorsal column and dorsal root ganglion, and lateral corticospinal tract are also involved, which result in the spastic weakness, and spinocerebellar tract involvement result in ataxia. So the things, ataxia is because of involvement of spinocerebellar tract, loss of proprioception and vibration is because of the involvement of dorsal column and the dorsal root ganglion, and the lateral corticospinal tract involvement results in spastic weakness. It is autosomal recessive. There will be progressive ataxia presents in adolescence caused by trinucleotide expansion of the GAA in the frataxin gene. There was another trinucleotide expansion which saw in the Fragile X syndrome, but that was CGG, right? Yeah, the chin and the giant gonads. Then for the Friedreich ataxia, there is GAA in the frataxin gene, so trinucleotide expansion is happening over here as well. Presentation is neurological dysfunction, cardiomyopathy, and diabetes mellitus. Neurological findings are related to the part of spinal cord affected. Corticospinal tract, if they are affected, they will lead to dysarthria, like inability to speak and limb weakness. Dysarthria is a motor speech disorder in which the muscles that are used to produce the speech are damaged, paralyzed, or weakened. The person with dysarthria cannot control the tongue or voice box and may slur the words. Sinocerebellar tract will result in ataxia, and dorsal column tract loss of proprioception and vibration sense. Dorsal root ganglion loss of deep tendon reflexes. Skeletal findings pes cavus, high arch feet, and kyphoscoliosis. Hypertrophic cardiomyopathy is also seen. Diagnosis is cervical spinal atrophy is seen on the imaging, and that is confirmed by genetic testing. We'll see for the frataxin protein. Friedreich ataxia is an autosomal recessive condition. There is a loss of function trinucleotide repeat expansion GAA in the frataxin gene. The clinical features include neurological side effects, cerebellar ataxia, dysarthria, loss of vibration and position sense, absent deep tendon reflexes, hypertrophic cardiomyopathy, skeletal deformities like scoliosis and diabetes mellitus. Prognosis: the mean survival age is 30 to 40 years. Mortality due to the cardiac dysfunction like arrhythmias and congestive heart failure can also occur. Seizures. Think of seizure when there is a sudden loss of consciousness, loss of postural tone, or delayed return to baseline mental status. In contrast to syncope, they will be 1 to 2 minutes. The return will be in 1 to 2 minutes, like for the seizures. Sudden loss of consciousness, loss of postural tone, and a delayed return to the baseline. Some patients may experience aura, lateral tongue laceration. That is very important diagnostic tool. That if there is a lateral tongue laceration, that was probably a seizure, and if it is a front tongue laceration, it is syncope. In the people who are malingering, who don't have seizures but they are pretending to have one, so look for the tongue. The tongue will not be lacerated on the lateral aspect. Urinary incontinence and perioral cyanosis. So for generalized seizure, so there are three things like generalized seizures, vasovagal syncope, and cardiogenic syncope. So the triggers for the generalized seizure can be fever, hypoglycemia, or sleep deprivation. The clinical features include with or without preceding aura, loss of consciousness and tone, tonic-clonic convulsions, and post-ictal state. Vasovagal syncope that can happen with a prolonged standing, physical and emotional stress. The clinical features of vasovagal syncope include a prodrome of presyncope like lightheadedness, pallor, and diaphoresis. Immediate return to baseline after the event. The cardiogenic syncope, the triggers are exertion and dehydration, and the clinical features include sudden loss of consciousness without prodrome, immediate return to the baseline after the event, and 1 to 2 minute return is happening in syncope, while in the cases of seizures, the return is prolonged or delayed than that. What are focal seizures? Etiology: structural abnormality, for example, tumor, genetic epilepsy, and maybe unknown. Clinical features include origin, one cerebral hemisphere, like focal seizures are not involving the whole brain as a whole, they are involving one cerebral hemisphere. Intact or impaired complex awareness, like if the awareness is intact, that is simple focal seizures. If the awareness is impaired, that is complex focal seizures. Then with or without secondary generalization, like they may become generalized and the whole brain can be involved in the long run. Diagnosis is MRI of the brain and electroencephalography. What are absence seizures? I'm sorry. The clinical feature is sudden impairment of consciousness, that is staring spells, preserved muscle tone, unresponsive to tactile and verbal stimuli, short duration like less than 20 seconds, simple automatism, frequently present, easily provoked by hyperventilation. So when you are diagnosing a child, so ask them to hyperventilate and they may elicit absence seizures in your clinic. Diagnosis is done by the EEG. 3 Hz spike wave discharges are seen during the episodes. Slow wave roots felt. Uh, on EEG, if there is 3 Hz spike wave discharges during the episodes, that is absence seizures. And if you are finding slow waves, that is a characteristic of Creutzfeldt-Jakob disease. That is a totally different disease, but they have mentioned it over here. Comorbidities include attention deficit hyperactivity disorder and anxiety. Treatment is done by the ethosuximide, thalamic T-type calcium channel blocker. So the key points about the absence seizure are that they are brief, less than 20 seconds long. They are associated with automatism like eye flickering and lip smacking. No post-ictal state is present. They can be provoked by hyperventilation. Diagnosis is EEG, will show 3 Hz spike wave, and treatment is ethosuximide. The clinical feature of absence seizures and inattentive staring spells. Absence seizure occurring during all activities. Length is less than 20 seconds and lack of response to the vocal or tactile stimulation. There will be presence of automatism. Inattentive staring spells occurring primarily during the boring episodes. Variable length, but often they are more than 1 minute. There are people response to the vocal or tactile stimulation, and there is no automatism. So this is inattentive staring spell. Simple febrile seizures. Common features are generalized and they are less than 15 minutes and do not recur within 24 hours. Treatment is just give acetaminophen and discharge the patient. Antipyretics can make child more comfortable but do not reduce the risk of future febrile seizures. Okay, so febrile seizures, the risk factors include fever from mild viral illness and family history. Diagnostic criteria is typically age 3 months to 6 years, no previous afebrile seizures, no meningitis or encephalitis, no acute metabolic cause. Management, abortive therapy for more than 5 minutes, and reassurance, give symptomatic care and antipyretics. Prognosis, normal development and intelligence, about 30% risk of recurrence and less than 5% risk of epilepsy. Febrile seizures versus meningitis. So febrile seizures are here and meningitis is over here. Clinical features, usually single episode, less than 15 minutes, rapid return to the baseline, that is simple febrile seizures. No signs of intracranial infection and age will be 6 months to 5 years. Diagnosis is clinical and no imaging or laboratory studies are required. Treatment is supportive care, for example, acetaminophen. For meningitis, associated seizures often prolonged or recurrent. Signs of intracranial infection including headache, vomiting, bulging fontanelle which is showing increased intracranial pressure, nuchal rigidity and altered mental status. The diagnosis is cerebrospinal fluid culture via lumbar puncture and treatment is intravenous antibiotics. Children with following alarming examination findings require immediate lumbar puncture. Signs of increased intracranial pressure like headache, vomiting and bulging fontanelle. Meningeal signs like nuchal rigidity and Kernig or Brudzinski's sign. The Kernig sign is when you flex the knee, so when you flex the neck, so the knees will be flexed. And there's a Brudzinski sign as well. I think that is when you try to extend the neck, extend the knees, so something happens. Okay, I always confuse them and I'm confusing them again. So let me check them. So here you can see there's a good mnemonic. They're saying that for the Kernig sign, remember the knee E. So initially the knee extension is painful. So if you're making the patient lie supine and you flex the hip and you try to extend the knee, so that will be painful for the patient. Then for the Brudzinski sign, there is N and K in the spelling. So neck flexion leads to knee flexion. Like if you flex the neck, so the knees are also flexed. So this is about the signs. Then we have prolonged altered mental status, that is post-ictal period will be more than 10 minutes in the meningitis, right? And there will be petechial rash. Now there is another syndrome that is called as the Landau-Kleffner syndrome. Kleffner syndrome, yeah. So it is epileptic condition that presents with a regression in language milestones after the normal development. So It is Landau-Kleffner syndrome, in which after achieving the normal milestone, there is a regression in the language milestones. There is another syndrome that is called as Lennox-Gastaut syndrome. Age of presentation is 3 to 5 years. Intellectual disability and seizure disorder. EEG will show interictal EED demonstrates slow spike wave pattern. So that is Lennox-Gastaut syndrome. It is a proper syndrome that presents at age 3 to 5 years, and there is also associated intellectual disability. So they have depicted Kernig sign over here. So Kernig sign is the one with the knee extension. So you try to extend the knee, and when the patient is lying with the thigh flexed on the abdomen, the leg cannot be completely extended. And this is the Kernig sign. Well, this one is involuntary flexion and knee flexion. This is the Brudzinski sign. Then we have Toad paralysis. What is Toad paralysis? One-sided paralysis hemiplegia after seizure post-ictal state, and it goes away. Hemiparesis or complete hemiplegia involving the extremities on one side, occurring after a focal or generalized seizure in the post-ictal stage. It is self-limiting and typically resolves within 36 hours. So after a person has seizures, there can be total paralysis, like half side of the body can become paralytic for about 36 hours, and that happens in post-ictal state, and that is called as total paralysis. Acute causes of hemiplegia in children. Hemiplegia means paralysis on one side. So seizures, history of generalized limb jerking or loss of consciousness, presence of post-ictal confusion or total paralysis. Total paralysis is a symptom after seizure in which the paralysis on one side occurs, and symptoms are self-resolving. Intracranial hemorrhage can cause acute hemiplegia in the children. History of trauma or bleeding disorder like hemophilia, signs of increased intracranial pressure, vomiting, and bradycardia, Cushing hypertension, Brady, what is that? The Cushing's triad is hypertension, bradycardia, and irregular breathing. Okay. Ischemic stroke, history of prothrombotic disorder like antithrombin 3 deficiency or cardiac diseases like patent foramen ovale, focal neurological deficits like hemiplegia, aphasia, and ataxia, hemiplegic migraine, onset in the adolescence and often positive family history, history of headache and visual aura, and symptoms are self-resolving. So all of these can cause acute hemiplegia in children: seizures, intracranial hemorrhage, ischemic stroke, and hemiplegic migraine. The next thing is breath holding spells. So a breath holding spell is an episode in which the child involuntarily stops breathing and loses consciousness for a short period immediately after a frightening or emotionally upsetting event or a painful experience. So that is a breath holding spell. Occurs most commonly in children aged 6 months to 2 years. Presents with cyanosis or pallor. Cyanotic ones are they present after crying, and pallid presents after minor trauma. Pallid means pale. Loss of consciousness followed by breath holding, pallor, and diaphoresis. This episode lasts less than 1 minute, and subsequent confusion and sleepiness for a few minutes. Follows minor injury or an upsetting event, leads to loss of consciousness. Patients typically recover without post-ictal period. Some patients experience recurrent episodes that usually stop by the age of 5, and some patients develop vasovagal syncope later in life. Then there is homocystinuria. There is a marfanoid habitus, ectopia lentis, increased arm to height ratio, breast bone dips inward or protrudes outward, decreased upper to lower body segment ratio, taller and slender build. There will be flat feet, arachnodactyly, joint hypermobility, kyphosis, and scoliosis. This is Marfanoid habitus, which is seen in both homocystinuria and Marfan syndrome. So homocystinuria is autosomal recessive. There is cystathionine deficiency. The clinical features resemble the Marfan syndrome, that is Marfanoid habitus, except the following. Fair hair and eyes will be present. A fair complexion will be there. There will be developmental delay, cerebrovascular accidents because of thromboembolic events, downward lens dislocation. In Marfan syndrome, we have upward lens dislocation, when in the homocystinuria, there is a downward lens dislocation. Ectopia lentis is present in both of them. Diagnosis: increased homocysteine and increased methionine. Treatment is vitamin B6, folate, and vitamin B12. Lowers homocysteine level. So if we give vitamin B6 or folate or vitamin B12, because they are responsible for the homocysteine metabolism, they convert the homocysteine into methionine. Then antiplatelet and these antiplatelets and anticoagulants can also help. They prevent the stroke, coronary heart disease, and venous thromboembolic disease, which can occur under the setting of homocystinuria, because homocystinuria is a risk factor for the development of atherosclerosis. Differential diagnosis of methanoid body habitus. These are Marfan syndrome and homocystinuria. So overlapping features include pectus deformity, tall stature, increased arm to height ratio, decreased upper to lower segment ratio, arachnotactyly, joint hyperlaxity, skin hyperelasticity, and scoliosis. Distinguishing features are autosomal dominant. There is a normal intellect, aortic root dilation, and upward lens dislocation is seen in the Marfan syndrome. While for the homocystinuria, the distinguishing features are autosomal recessive, there will be intellectual disability, thrombosis, downward lens dislocation, metabolic anemia, and fair complexion. So in the Marfan syndrome, we can also find regurgitation, dissection, mitral valve collapse. There is another syndrome that is called as Sturge-Weber syndrome. So in the Sturge-Weber syndrome, there is ipsilateral choroid plexus enlargement, as you can see over here, and leptomeningeal enhancement can also be seen. Okay, due to venous congestion from the capillary venous malformation. So this leptomeningeal enhancement is seen due to venous congestion from the capillary venous malformation. Sturge-Weber syndrome. Sturge-Weber syndrome is the one with the port-wine stain. There is basically a triad of three things, that is port-wine stain, seizures, and glaucoma with intellectual disability. Port-wine stain, seizures, glaucoma, and intellectual disability. There will be facial port-wine stain, leptomeningeal capillary venous malformation, intellectual disability, seizures originate focally and then become generalized, glaucoma, visual field defects like homonymous hemianopia, diagnosis, MRI of the brain with contrast, and they detect the intracranial vascular malformation. So there is a mnemonic for that as well. Sturge is seizures, T is for tram track calcifications, U means unilateral, port-wine stain, and weakness, usually opposite side. So it's too fine, like they are written that usually that is seen on the opposite side. So like the port-wine stain is seen on one side and the weakness will be on the opposite side of that stain. There is mental retardation, glaucoma, and epilepsy. Then there is a table before that. I think, yeah. Diagnoses MRI brain and detects the intracranial vascular malformation. So this table about the Sturge-Weber syndrome is telling us about the pathophysiology, that there is a mutation in the GNAC gene. The clinical features include port-wine stain, trigeminal nerve CNV1 and V2 distribution, leptomeningeal capillary venous malformation, seizures with or without hemiparesis or hemiplegia. Hemiparesis and hemiplegia is one and the same thing. So seizures with or without hemiparesis and hemiplegia can be seen. Intellectual disability, visual defects, and glaucoma. Glaucoma is a group of eye conditions that damage the optic nerve. This damage is often caused by the abnormally high pressure in your eye. Diagnosis, MRI of brain with contrast. Management, by the laser therapy, anti-epileptic drugs, and intraocular pressure reduction. There is a syndrome called as Klippel-Trenaunay syndrome. Malformations are capillary, venous, and lymphatic. They can be limb overgrowth, and port-wine stain can also be present. So port-wine syndrome is present in Sturge-Weber syndrome and also can be present in the Klippel-Trenaunay syndrome. It involves the lower extremity rather than the face, as seen in the Sturge-Weber syndrome. So if this port-wine syndrome is present in the lower extremity, that is a Klippel-Trenaunay syndrome. You must suspect that. And if it is present in the face, then you must suspect Sturge-Weber syndrome. The next condition is that the Klippel-Trenaunay syndrome does not have any neurological abnormalities, while the Sturge-Weber syndrome has a bunch of it. Like there is seizures and intellectual disability, visual field defects, and even glaucoma. What is neurofibromatosis type 1? Epidemiology, it is autosomal dominant. NF1 mutation is present in them. Manifestation is cafe au lait spots, clustered freckles, axilla inguinal, less nodules present in the eye, neurofibromas, and optic gliomas. Autosomal dominant condition, the features are cafe au lait macules, In axillary and inguinal freckling, there will be disc nodules, which are basically iris hematomas and neurofibromas all over the body, associated with the neurological disorders like congenital defects, learning disabilities, and seizures, and also optic gliomas. Early yearly ophthalmology examination screen for the optic gliomas in the patients who have diagnosed neurofibromatosis type 1. MRI of the brain and orbits is required for any vision changes. Now, in this picture, you can see that disc nodules look something like this. If you can see them, like these are dots, freckles like 1, 2, 3, 4 in the iris. Then there are neurofibromas, which are lump on skin and lump under the skin. Cafe au lait spots are basically brown pigmented spots like this and like this. Then we have skin fold freckling in the inguinal folds and also in the fold. Neurofibromas, cafe au lait. Just give me a second. Yeah, axillary folds and inguinal folds can show freckling. As you can see, the axillary fold freckling over here. Cafe au lait spots. Now, in this picture, you can see that there are cafe au lait spots on the arm of this child. These are the neurofibromas on the breast area and the shoulder area. Then tibial bowing can also be present. Plexiform neurofibromas, these ones, and axillary fleckering can also be present. Freckling, I'm sorry. So then we have a conversion disorder present in the occurs in the presence of witness. So this one is a differentiating point from the seizures and a conversion disorder. Conversion disorder is that a person will most often have some emotional toll, like he will be having a fight or something, and then the legs will stop working and then the person will fall down. That is a conversion disorder. NF1 skin extremities examination should be carried out yearly. Macrosomia associated with hemorrhages. Macrosomia is associated with a traumatic or device assisted delivery, leads to intraparenchymal or subdural hemorrhage. These hemorrhages are usually small and do not require interventions. Seizures and complications of the bacterial meningitis, they are focal instead of generalized. Nocturnal headache and morning vomiting are red flags for the intracranial pathology. Lumbar puncture in neonates. Neonates don't experience herniation after lumbar puncture as their open fontanelles relieve the intracranial pressure and there is no need of CT. Okay. So that is why we can do the lumbar puncture in the neonates, right? Even if we are suspecting meningitis, do it because these children are not going to develop brain herniation because of the lumbar puncture. It's a very good thing because with the increased intracranial pressure, we don't perform the lumbar puncture because of suspected risk of brain herniation. Then what is the concept of optic gliomas, which are seen in the neurofibromatosis type 1? Optic gliomas manifest as unilateral vision loss, proptosis, esotropia, that is the eye will move inside, and optic disc pallor. So this is an optic glioma. Here you can see, if you can see, these are disc nodules, which are dots on the iris. Then axillary and inguinal freckling will also be present. These are the earliest skin manifestation of neurofibromatosis type 1. Cafe au lait spots are the earliest manifestation of neurofibromatosis type 1 and they appear in infancy. Then we have this scoliosis. Neurofibromatosis begin benign peripheral nerve sheath tumors and there can be pseudoarthrosis as well. 15% of the patients with age less than 6 develop low-grade optic gliomas, mostly asymptomatic but can grow large enough to cause symptoms such as decreased visual acuity, alterations in color vision. Optic nerve atrophy looks like as optic disc pallor. Proptosis. This also occurs in retinoblastoma, but in retinoblastoma, age of presentation is less than 2 years old, and also there is no skin finding. RB gene, osteosarcoma, retinoblastoma. Yeah. So what are we talking about basically? I'm sorry, we're talking about neurofibromatosis type 1, right? So the RB gene, if that is defective, that can also result in osteosarcomas. Proptosis is protrusion of eyeball. Exophthalmos means the same thing. As you can see in this picture, that the eye is being protruded outwards. Neurofibromatosis type 1 and 2, there is a difference between both of them. So now let's see them here. The diagnosis is neurofibromatosis type 1 that is von Reckling-Gossen's disease. There are 17 letters in von Reckling-Gossen's, which mean that which is an easy way or a difficult way to remember that the location of mutated gene is on chromosome number 17. Gene mutation: NF1 tumor suppressor gene codes the protein neurofibromin, and the clinical feature, the main clinical features are cafe au lait spots, multiple neurofibromas, Lisk nodules, optic gliomas. Optic gliomas manifest as unilateral vision loss, proptosis, esotropia, and optic disc pallor. Talking about neurofibromatosis type 2, these are central neurofibromatosis. Gene mutation is NF2 tumor suppressor gene. Code for the protein Merlin. Location of the mutated gene is chromosome number 22, NF2 22. And main clinical features are bilateral acoustic neuromas and bilateral cataract as well. An acoustic neuroma, vestibular schwannoma, is a benign tumor that develops on the balance vestibular and hearing. The pressure on the nerve from the tumor may cause hearing loss and imbalance. Then we have tuberous sclerosis. So for the pathophysiology, uh, there are mutations inherited or de novo in the TSC1 or TSC2 gene. They are autosomal dominant. The clinical features, dermatologic manifestations include ash leaf spots like these. They are different from the cafe au lait spots because they are hypopigmented, while the cafe au lait spots were hyperpigmented. Then angiofibroma on the angiofibromas of the malar region, as you can see this thing. Then Sjagren patches can also be present. The neurological manifestations include CNS lesions like subependymal tumors, epilepsy, for example, infantile spasms, intellectual disability, autism and behavioral disorders, for example, hyperactivity, cardiovascular rhabdomyomas, and renal angiomyolipomas. Surveillance, tumor screening, I'm sorry, regular skin and eye examination, serial MRI of the brain and kidney, baseline echocardiography and serial ECG, based on electroencephalography and neuropsychiatric screening. So there is a orange peel-like plaque on the lower back. These are Sjagren patches. Cardiac rhabdomyoma is a known cancerous tumor. A tumor can interfere with the way the heart works, blocking blood flow to vital organs and causing an abnormal heart rhythm, that is arrhythmia. Cardiac rhabdomyomas naturally shrink during the childhood. Then here you can see angiomyolipomas are the most common benign renal tumors. Most of these neoplasms are found incidentally on imaging, however, symptomatic presentation does exist. Renal angiomyolipomas are typically composed of smooth muscle, blood vessels, and adipose tissue, as the name indicates. Angi for the blood vessels, M for the smooth muscles, myolipoma for the adipose tissue. So this is a Google picture about the neurology. So features of tuberous sclerosis include hamartomas. H is for the hamartomas in the CNS and skin, angiofibromas, mitral regurgitation, ash leaf spots, cardiac rhabdomyomas. Then tuberous sclerosis is a disease which contains these problems: autosomal dominant, mind, intellectual disability, renal angiomyolipomas, and seizures and Sjagren patches. So the next thing is about the increased intracranial pressure. Increased intracranial pressure, the etiology for that can be a traumatic brain injury or hemorrhage, intracranial mass or infection, hydrocephalus, and idiopathic intracranial hypertension, which can be seen in the obese young women who are using OCPs, growth hormone, tetracyclines, and retinoids. I'm doubtful about the growth hormone thing. The clinical feature is headache, vomiting, and lethargy, bulging fontanelles, and papilledema. Diagnosis is by the brain imaging. Complications include cerebral herniation and ischemia. We are not supposed to perform the lumbar puncture in the people with increased intracranial pressure, but we can do that in children because they have fontanelles which can decrease the pressure. Then tuberous sclerosis also had periungual fibromas like these, periungual fibromas above the fingers. Okay. Then these are dural venous sinuses. Okay, so they're same as in the adults. So let's start from here. So this one is parietal sinus. This is the falx cerebri, which is dividing the two hemispheres. Like suppose this is the brain, like this, the cut section of the brain. So the falx cerebri is present over here. It is separating the two hemispheres from each other. Then the bridging veins are like this. These are connecting the extradural. These are basically draining into the extradural system. So whenever the person is having rapid falls, so these can get torn, and when they are torn, so the person can have subdural hemorrhages, subdural hematoma. That this is inferior sagittal sinus. So the inferior sagittal sinus is this one. Then tentorium cerebelli is this one. Superior pectoral sinus, great cerebral vein. This superior sagittal sinus is over here. Then straight sinus is this one. Confluence of sinuses. Transverse sinus is this one. Fox cerebri. Occipital sinus is like this one. Sigmoid sinus. And inferior pectoral sinus and internal jugular vein and anterior and posterior intercavernous sinuses. Then we have flow of CSF. So you must remember the flow of CSF, like from where it starts and where it goes, to understand the concept of hydrocephalus. So this one is CSF filtered from the plasma by the choroid plexus, and the choroid plexus is present at the ventricles, like specifically in the lateral and the third ventricle. So that from the lateral ventricles, it enters the third ventricle. From the third ventricle, by aqueduct of Sylvius, it enters the fourth ventricle, and from the fourth ventricle, it goes CSF passes from the ventricular space into the subarachnoid space, and then from the subarachnoid space, CSF is reabsorbed into the venous system by the arachnoid granulation. Hydrocephalus. You can see severe hydrocephalus in a newborn. There is excessive ventriculomegaly, and like this. Okay. So symptoms are poor feeding. So there will be poor feeding, irritability, decreased activity, vomiting. Physical examination will show tense and bulging fontanelles, prominent scalp veins, widely spaced cranial sutures, rapidly increasing head circumference. Diagnosis: acutely symptomatic patients, CT scan. Stable and asymptomatic patients, we can do sedated MRI. Okay, and ultrasound requires widely open anterior fontanelle. If it is not present, then we have to go for CT or MRI. Most useful in the infants who are less than 6 months. Treatment is shunt placement. Hydrocephalus in children. It is caused by the impaired CSF circulation, impaired CSF absorption, or excessive CSF production. The clinical manifestations include macrocephaly or rapidly enlarging head circumference, prominent scalp veins, full anterior fontanelle if open. It closes by 18 months. So if it is open, so it will be full. It will be full. Behavioral changes or developmental delay. Signs of increased intracranial pressure are headache and vomiting, papilledema, hypertension, bradycardia with decreased respiration, which is a part of Cushing's triad, which include hypertension, bradycardia, and abnormal or irregular breathing. Evaluation include neuroimaging like CT brain. Signs of intracranial pressure may not be present if the anterior fontanelle is open, because that will bypass, or that will diffuse the effect of increased intracranial pressure to some extent. Symptoms of the increased intracranial pressure include poor feeding, irritability, decreased activity, and vomiting. Physical exams are tense and bulging fontanelle, prominent scalp veins, widely spaced clinical sutures, and rapidly increasing head circumference. The best diagnostic approach in symptomatic children with a rapidly increasing head circumference is to perform the diagnostic imaging. A CT scan of the brain is the best initial choice in an infant who is acutely symptomatic. A CT reveals ventricular dilation as well as infant's anatomy. In an otherwise stable and asymptomatic infant, a sedated MRI could be considered to spare the child from radiation exposure. Both CT and MRI would provide much greater detail than ultrasound, which requires a widely open anterior fontanelle and is most useful in the infants under 6 months of age. Treatment of hydrocephalus consists of a shunt that is placed from the ventricle to the peritoneum, pleura, or right atrium, which allows the excess CSF to drain rather than continue to collect in the ventricles. Then, so it is basically a U-bolt snapshot. So a lumbar puncture may be helpful in improving the symptoms of normal pressure hydrocephalus, which is seen in adults. Also, the lumbar puncture is helpful if the meningitis is suspected. The patient has had some, okay, so this the patient in the question stem had the symptoms for 1 month, which makes the meningitis unlikely. The CT would provide more diagnostic. Forget about this one. So yeah, so this is it. The next thing is ventricular peritoneal shunt and how is it placed. So this is the concept of ventricular peritoneal shunt. It one end is placed in the ventricle while the other in the peritoneal cavity. Subcutaneous catheter is placed in this is peritoneal cavity. Like okay. Then traumatic brain injury or TBI. Traumatic brain injury can be mild and can be severe as well. So for the mild ones, the GCS is 13 to 15, loss of consciousness less than 5 minutes, headache, amnesia before after injury for less than 24 hours, vomiting, and alteration in the mental status at the time of injury. Severe, there will be focal neurological deficits, skull fracture, seizures, loss of consciousness for more than 5 minutes, and persistent altered mental status. Diagnosis: mild traumatic brain injury. Observe the patient for 4 to 6 hours. Head CT without contrast. Improvement during observation or normal CT scan is an indication to discharge the patient with clear written instructions with return precautions. Severe brain injury, CT without contrast, close inpatient monitoring, and neurosurgical consultation. Then the next thing is about evaluation of head trauma in children aged 2 to 18. Clinical scenario: any of the following. If the child is having focal neurological findings, skull fracture, especially the signs of basilar skull fracture, seizures, persistent altered mental status, like agitation, lethargy, and slow response, prolonged loss of consciousness more than 5 minutes, uh, head CT without contrast. I'm sorry for that. So prolonged loss of consciousness for more than 5 minutes and head CT for contrast is done. If any of these are is present, if GCS is 15 with any of these, any of the following: vomiting, then we have headache, questionable or brief loss of consciousness, injury caused by high risk mechanism of injury, severe mechanism of injury. They include car crash with the patient, ejection, passenger fatality, or rollover, pedestrian versus car, fall of height more than 5 feet, or head hit by high impact object. The clinician preference: observe for 4 to 6 hours or perform the head CT without contrast. Minor head trauma, GCS 15 with non severe mechanism and no vomiting, headache, loss of consciousness, or signs of fracture. In these situations, we don't perform head CT. Okay. Then the next thing is about the PCARN rule. Pediatric traumatic brain injury, we follow the PCARN rule. PCARN rule means that if it is a high risk fracture for age less than 2 years, altered mental behavior, fussy behavior, loss of consciousness, severe mechanism of injury, fall more than 0.9 meter, 3 feet, high impact motor vehicle collision, non-frontal scalp hematoma, and palpable skull fracture. So these things are called as high risk features. High risk features for age more than 2 to 18 years. Yes, I think it is years. Altered mental status, somnolence and agitation, loss of consciousness, severe mechanism, fall more than 1.5 meter, and high impact and motor vehicle collision, vomiting and severe headache, basilar skull fracture or signs, for example, CSF rhinorrhea. Management is head CT scan without contrast. Concussion. I'm sorry. A concussion is a traumatic brain injury that affects your brain function. This is skull and brain. Direct impact injury happening over here. Then there is a counter group injury. Because of the shake, acceleration and deceleration brain injury, and blast injury. So there are 3 types of injuries which can occur. Concussion symptoms: headache or a feeling of pressure in the head, temporary loss of consciousness, confusion or feeling as if in a fog, amnesia surrounding by the traumatic events, dizziness or seeing stars, ringing in the ears, nausea and vomiting, slurred speech, delayed response to questions, appearing dazed and fatigued. So what is the concussion? Concussion is a traumatic brain injury that affects your brain function. Effects are usually temporary, can include headaches and problem with concentration, memory, balance, and coordination. Concussions are usually caused by a blow to the head. Clinical features include transient neurological disturbances like dizziness, disorientation, amnesia, and mild traumatic brain injury. No structural or intracranial injury is found. Management: remove from the same day physical play, neurological evaluation, rest for more than 24 hours, gradual return to the normal activity if the symptoms do not worsen. Physical, light aerobic exercises, non-contrast sports and contact sports. Neurocognitive, limited screen time, school accommodation, for example, frequent breaks and shortened days. Then we have post-concussion syndrome. So the post-concussion syndrome, the risk factors include non-adherence to the gradual return to play protocol after concussion and history of multiple concussions. The clinical features include prolonged, more than 4-week concussion symptoms after the mild traumatic brain injury, headache, dizziness, sleep disturbance, mood changes and cognitive impairment, no structural intracranial injury. Management is by symptomatic care and activity as tolerated. Then we have intraventricular hemorrhage. So in children, the intraventricular hemorrhage is happening because of the germinal matrix hemorrhage. So rib retinopathy of prematurity. I'm sorry, the mnemonic is retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. High flow oxygen, free radicals increase oxygen tension. So I don't know what the rib was for. So germinal matrix, this is the lateral ventricle, and the germinal matrix is located over here. It can bleed. Hemorrhage extending into the lateral ventricle. Acute changes in the blood flow through the germinal matrix lead to hemorrhage either within the germinal matrix or into the lateral ventricle. Risk factors are prematurity. Neonates who are born less than 32 weeks are at highest risk of germinal matrix involutes. It involutes by 32 weeks. Very low birth weight, less than 1500 grams. Low birth weight is less than 2.5 kgs, while very low birth weight is less than 1.5 kgs. Acute changes in the cerebral perfusion, hypotension, hypoventilation, and hyperventilation is a risk factor, right? Then presents with 3 to 4 days of birth. Features include mostly asymptomatic and symptomatic patients, severely neurological changes like lethargy, hypotonia, apnea or seizures, bulging fontanelles, increased head circumference, anemia, tachycardia due to hemorrhage like more than 100 beats per minute. The diagnosis: cranial ultrasound of all neonates born at more than 32 weeks of gestation at age 1 to 2 weeks. Hyperechoic material, as you can see that we are doing cranial ultrasound of neonates like in the first month, so the fontanelles are wide open and we can perform the ultrasound very effectively. So hyperechoic material within the germinal matrix with or without extension to the ventricles or parenchyma. Treatment is basically symptomatic treatment, blood pressure stabilization and anti-seizure medication. So this is intraventricular hemorrhage of the prematurity, this one and this one. Intraventricular hemorrhage pathophysiology and risk factors: ruptured germinal matrix vessels, prematurity and very low birth weight. The clinical findings are often asymptomatic, seizures or apnea, full fontanelle, and acute anemia. Diagnosis is by the cranial ultrasonography. Gradings are there are 4 grades to that. Hemorrhage limited to the germinal matrix, grade 1. Grade 2 is intraventricular hemorrhage with less than 50% of the ventricle. Grade 3 is more than 50% of the ventricle or ventricular dilation. And grade 4 is parenchymal hemorrhage. So these are the 4 grades. Let me repeat them. Grade 1 is hemorrhage limited to the germinal matrix. Grade 2 is intraventricular hemorrhage, less than 50% of the ventricle. The grade 3 is more than 50% of ventricle or ventricular dilation, and grade 4 is parenchymal hemorrhage. Intracranial hemorrhage due to vitamin K deficiency. Newborns are vitamin K deficient due to the following reasons. Firstly, there is poor placental transfer of vitamin K, absent gut flora to synthesize vitamin K, and immature liver function, that is poor vitamin K utilization. Early onset vitamin K presents within 1 week of the following. Within 1 week with the following, that is early bruising, mucosal bleeding, and gastrointestinal hemorrhage. Late onset vitamin K deficiency presents with age 2 weeks and 6 months with intracranial hemorrhage. Layered hyperdense fluid collection within enlarged with ventricle is suggestive. Prevention is intramuscular vitamin K at birth. That is prevention, not treatment. Remember that. Then the next one is infant botulism. The causes are raw honey ingestion, ingestion of inhaled environmental spores of Clostridium botulinum, Incidence is highest in California and Pennsylvania and Utah. These areas have the greatest soil botulism spores. The clinical features are bilateral bulbar palsies, uh, which present with a ptosis, sluggish pupillary response to the light, and poor suck and gag reflex, followed by symmetric descending flaccid paralysis, which is called hypotonia, constipation, and drooling. Treatment is by the respiratory support, NG tube feeding, IV human derived botulism immunoglobulin, administer it even before diagnostic confirmation of stool spore or toxin. Administer it even before the diagnostic confirmation of stool spore toxin. Give IV derived human botulism if you are suspecting it clinical on the clinical grounds. What is the difference between bulbar palsy and pseudobulbar palsy? The bulbar palsy is a lower motor neuron lesion affecting the CN7 to CN12. Flaccid paralysis of the pharynx and larynx can be seen. The pseudobulbar palsy is a bilateral upper motor neuron disorder, spastic paralysis of the pharynx and larynx. Airway clearance is an emergency. So if I could zoom it in and I could tell you that what the problem actually is. In bulbar palsy, the problem is that the lower motor neuron nuclei or the nerves themselves are damaged, right? So we find flaccid paralysis, which is a characteristic symptom of the lower motor neuron lesions. In the case of pseudobulbar palsy, these are the cranial nerve nuclei which are present over here. These are supplied by upper motor neurons. If the upper motor neurons are damaged, so we find spastic paralysis of the pharynx and larynx, and airway clearance or emergency can occur. Okay. So there will be spastic paralysis. Next thing is, so differential diagnosis of the flaccid paralysis. That flaccid paralysis can be seen in the infant botulism, foodborne botulism, and Guillain-Barré syndrome. So pathogenesis for the infant botulism, it is caused by ingestion of Clostridium botulinum spores from environmental dust. Presentation is descending flaccid paralysis. Treatment is by the human-derived botulism and immunoglobulin. Foodborne botulism, ingestion of the preformed Clostridium botulinum toxin in canned food. Presentation is descending flaccid paralysis, and treatment is equine-derived botulism toxin, that is horse toxin. So this is infant botulism, and these are foodborne botulism. These are slightly different conditions. This comes from environmental dust, and this comes from the canned food. Yep. And for the treatment, we use human derived botulism immunoglobulin here, and here we use equine derived botulism toxin. For the Guillain-Barré syndrome, it is autoimmune peripheral nerve demyelination. Presentation is ascending flaccid paralysis, and the treatment is pooled human immunoglobulins. So here you can see the differences between the bulbar and pseudobulbar palsy. Pseudobulbar palsy is an upper motor neuron lesion. The cranial number 5 and 7 are involved. Facial expressions and mastications are disturbed. Bilateral degeneration of the corticobulbar tract. Increased gag reflex, tongue spasticity, spastic dysarthria. And spastic dysarthria means there is a Daffy Duck sign, and multiple sclerosis and motor neuron disease can present like this. The bulbar palsy, lower motor neuron lesion, cranial nerve 9 and 11. There is a diminished gag reflex, tongue fasciculations and wasting will be there. Jaw jerk will be normal. Unilateral raspy noise, and if it is bilateral, then there will be nasal speech. And Guillain-Barré syndrome, stroke, and motor neuron disease can present like that. Then Guillain-Barré syndrome. The pathophysiology is immune-mediated demyelinating polyneuropathy, preceding gastrointestinal, Campylobacter or respiratory like influenza virus infection. Clinical features are paresthesias, neuropathic pain, symmetric ascending weakness, decreased or absent deep tendon reflexes, autonomic dysfunction like arrhythmias or ileus, inability of the intestine to contract normally and move waste out of the body, and respiratory compromise. The diagnosis, it is mainly clinical, and supportive findings include cerebrospinal fluid will show an increase in the protein and normal leukocytes, abnormal electromyography and nerve conduction. Management is monitor autonomic and respiratory function, intravenous immunoglobulins and plasmapheresis. Demyelination of the peripheral nerves will result in ascending paralysis, and that will be a symmetric weakness, weak or absent deep tendon reflexes, respiratory failure and autonomic symptoms, blood pressure and heart rate instability or arrhythmias, and EDS will also be present in these patients. Okay. Then preceding respiratory or GIT infection like by the Campylobacter or influenza. Management is if Guillain-Barré syndrome is in a stable patient, the very next step is to assess the pulmonary function with spirometry, forced vital capacity and negative inspiratory force, monitor respiratory muscle strength. A decline in forced vital capacity less than 20 ml per kg indicates impending respiratory failure. Do endotracheal intubation. Additional indications for elective intubation are respiratory distress, severe dysautonomia, for example heart rate and blood pressure instability or widened pulse pressure. Treatment is IV immunoglobulin and plasmapheresis. Now, what are the differential diagnoses of the neuromuscular weakness? The upper motor neuron lesions include leukodystrophies, vasculitis, brain mass, and vitamin B12 deficiency. Peripheral nerve involvement include hereditary primary motor sensory neuropathies, Guillain-Barré syndrome, diabetic neuropathy, amyloid neuropathy like myeloma and lead poisoning. Neuromuscular junction problems include myasthenia gravis, Lambert-Eaton syndrome, organophosphate poisoning, and botulism. Anterior horn cells problems include spinal muscular atrophy, amyotrophic lateral sclerosis, paraneoplastic syndromes, and poliomyelitis. And muscle fiber problems include muscular dystrophies, polymyositis and dermatomyositis, hypothyroidism, corticosteroids, and HIV myopathy. So here's CK. What is that? Hypothyroidism, inflammatory myopathies, statin, steroid. Here's CK. So what is that? Steroid muscle enzymes are normal. I don't know, they're just weird mnemonics. So statin causes a myopathy via decreased coenzyme Q10 synthesis. Decreased energy production will result in myopathy. So this was tested in one of the U-Board questions. The next point is about phenylketonuria. Diagnosis: newborn screening, tandem mass spectrometry. We use tandem mass spectrometry as a part of newborn screening. The tandem mass spectrometry is a vital technique in identifying and quantifying the different metabolites. Later in life, quantitative amino acid analysis can be done. Treatment: low phenylalanine diet, cereals, starches, fruits, vegetables, and phenylalanine free milk is recommended. High protein food is contraindicated in these people. Phenylketonuria pathophysiology: autosomal recessive mutation in the phenylalanine hydroxylase. Failure to convert the phenylalanine into tyrosine results in the hyperphenylalanemia and neurologic injury. The clinical features include severe intellectual disability, seizures, musty body odor, hypopigmentation involving the skin, hair, eyes, and brain nuclei. Diagnosis: newborn screening, tandem mass spectrometry, quantitative amino acid analysis with increased phenylalanine level. Phenylalanine is an amino acid, and treatment is dietary restriction of the phenylalanine. Then we have myotonic muscular dystrophy, means delayed muscle relaxation, like it is myotonic, right? So myotonic dystrophy, autosomal dominant. Now remember, this is the third autosomal dominant condition we have read so far. There is CTG trinucleotide repeat expansion, repeat length inversely correlating with the age of onset. So more is the repeat length, the lesser will be the age of onset. It will present early onwards. Clinical presentation: myotonia, delayed muscle relaxation. Childhood form will have cognitive and behavioral problems. Infantile form will have hypotonia and arthrogryposis. Arthrogryposis describes congenital joint contracture in two or more areas of the body. Okay. Myotonic dystrophy. Associated conditions are arrhythmias, cataracts, excessive daytime sleepiness, and testicular atrophy or infertility. Diagnosis is done by genetic testing, and treatment is by symptomatic care. Then it is an autosomal dominant condition. Physical examination include ptosis, temporary wasting, thin cheeks, emaciated extremities, atrophy of thenar and hypothenar eminences, inverted V-shaped upper lip, testicular atrophy, delayed relaxation. All the muscles are affected: skeletal muscles, smooth muscles, and cardiac muscles. All of them will be affected. So skeletal muscles will have prominent in face, forearm, hands, ankle dorsiflexors, for example bilateral foot drop. Smooth muscle dysphagia, increased risk of aspiration pneumonia, and cardiac muscle will have conduction problems like arrhythmias. Other manifestations are cataract, testicular atrophy, frontal baldness, and insulin resistance. So muscular dystrophies, they can be Duchenne, Becker, and myotonic. We have talked about myotonic right now. Let's read this table as well. So for the Duchenne and Becker palsy, the genetics are X-linked recessive, deletion of the dystrophin gene on chromosome number XP21. Clinical presentation of the Duchenne muscular atrophy is that onset is age 2 to 3 years. It is progressive weakness. There will be a Gowers maneuver, calf pseudohypertrophy, like there will be fibrofatty replacement. Comorbidities include scoliosis and cardiomyopathy. Prognosis is wheelchair dependence by adolescence and death by age 20 to 30 years from respiratory or heart failure. Then we have the Beckel's deformity, that is also X-linked recessive, and the same deletion of dystrophin gene on the chromosome number XP21 is happening. The clinical presentation is the age of onset is 5 to 15 years. Milder weakness compared to the Duchenne muscular dystrophy will be there. Then there is cardiomyopathy, and death will be by age of 40 to 50 from years. Then the next thing is about the myotonic dystrophy. So it is an autosomal dominant condition due to expansion of a CTG trinucleotide repeat in the DMPK gene on the chromosome number 19q 13.3. Onset is age 12 to 30, like it has the late onset. Facial weakness, hand grip, myotonia and dysphagia. So sometimes they give you a scenario when the patient grips when you shake the hand of the patient and the patient cannot leave the grip, like there is a prolonged grip of the patient after the handshake. There are arrhythmias, cataracts, balding, testicular atrophy and infertility. Prognosis, death from the respiratory or heart failure depending on the age of onset. So then the next thing is about the brain abscess. The risk factor for the brain abscess is, firstly, the brain abscess. The risk factors are otitis media, mastoiditis, like the dental mastoiditis can cause otitis media. Then there is dental infection, sinusitis. Sinusitis can cause brain abscess, and cyanotic heart disease, like tetralogy of Fallot, it somehow can cause brain abscess. Present with severe headache, which is not relieved by the NSAIDs. Worse at night. Intracranial pressure naturally increases in supine position due to the gravity. Associated with morning vomiting. Diagnosis: contrast enhanced CT and MRI of the brain. Neuroimaging shows ring enhancing lesions and surrounding edema. Ring enhancing lesions are seen in the toxoplasmosis, but there will be multiple rings. CNS lymphoma, Epstein-Barr virus, single ring, and brain abscess, single ring with edema. So if there is single ring with edema, it is brain abscess. Just a single ring, you must suspect CNS lymphoma by the Epstein-Barr virus, and toxoplasmosis have multiple rings, and brain biopsy should also be done. Migraines. So there is a logarithm or flow sheet about it. Let me zoom it in. Management of migraine in the pregnancy. So the management of migraine in pregnancy, if I could come here. Yeah. So here you can see that management of migraine in pregnancy, non-pharmacological therapy, rest, hydration and heat. Then we can give acetaminophen, antiemetics like promethazine, codeine and caffeine, butalbital, non-steroidal anti-inflammatory drugs like naproxen can also be given. Opioids, for example, oxycodone, can be used in conjunction with acetaminophen. What can be used? Antiemetics can be used in conjunction with acetaminophen, and the non-steroidal anti-inflammatory drugs must be used in second trimester only. Okay. Then we have, what do we have? So migraines. So migraines, unlike migraine in adults, migraine in children are bifrontal and they are of shorter duration. If occipital headache is presented, it should raise the concern of structural lesion. Treatment: first line treatment is supportive, lying in the dark, quiet room, cool cloth on the forehead. Acetaminophen or NSAIDs can also be given. Second lines are triptans, oral, intranasal, and injectable. Migraines with aura. So migraines with aura in girl taking the oral contraceptive pills. Discontinue the OCPs immediately because estrogen mediated increased risk of thrombosis can lead to ischemic stroke. Okay, this can happen. Then the next thing is about this can happen, ischemic stroke. So migraine in children, there's a table about that. Epidemiology: equal incidence in boys and girls until puberty. Increased risk of in adolescent girls associated with the oral contraceptive pills as well as uh, there is an increased risk of development of migraine in adolescent girls. It is associated with oral contraceptive pills as well. Discontinue because they can cause ischemic stroke in a migraine with aura. Then clinical features include pulsatile throbbing headache lasting for hours to days, bilateral or unilateral. Migraines are usually unilateral but not in the kids. Associated symptoms include photophobia and phonophobia, nausea and vomiting, autonomic symptoms like facial sweating, tearing, nasal congestion, with or without preceding aura like scintillating scotoma. Normal neurological exam. Abortive treatment is acetaminophen, non-steroidal anti-inflammatory drugs, triptans, antiemetics like promethazine and prochlorperazine, and ergots like dihydroergotamine can also be given. So there are different types of headache. This one is called as sinus headache. This is tension headache associated with some sort of stress. This is migraine, but in children it is bifrontal, and this is cluster headache. And this is a picture of aura. Then the mechanism of action of triptans. How do they act? Migraine pathogenesis and triptan mechanism of action. So basically migraine, give me a second. I think the triptans are serotonin antagonists, right? So they decrease the neurogenic inflammation, decrease the CGRP release, and they cause vasoconstriction. Okay. Calcitonin gene related peptide. So increased cerebral excitability, cortical spreading depression, that will lead to release of CGRP. CGRP causes vasodilation, sensitization of the meningeal trigeminal nerve that leads to increased pain afferents. Also CGRP will lead to increased neurogenic inflammation that also sensitizes the meningeal trigeminal nerve and meningeal trigeminal afferents that result in increase in pain sensation. So the triptans will come. The triptans, by acting on the serotonin 1D receptor, they decrease the CGRP release, and by acting on the serotonin 1B receptors, they cause vasoconstriction. Okay, got it. So I have two vasoconstriction. Okay, so indication for the neuroimaging in a child with a headache. The indication is history of coordination difficulties, presence of numbness or tingling, focal neurological signs, history of headache that causes awakening from sleep, history of increasing headache frequency. These are indications for neuroimaging in the child with a headache. Migraine is an episodic neurological disorder that results in severe unilateral throbbing headache, often associated with photophobia and phonophobia, and nausea or vomiting. They may be accompanied by aura, focal reversible neurological symptoms that precede or accompany the headache. Estrogen-containing contraceptives are contraindicated in the patient with a migraine with aura due to the increased risk of ischemic stroke. What is cerebral palsy? So, upper motor neuron symptoms. In cerebral palsy, the upper motor neuron symptoms like hyperreflexia, hypertonia, commando crawl. I think it is commando crawl, and equinovarus deformity can also be seen. Cerebral palsy is a non-progressive motor dysfunction. Prematurity is a great risk factor for this one, like less than 32 weeks. That's why give magnesium sulfate to decrease the risk. We give magnesium sulfate to decrease the risk of premature deliveries to avoid cerebral palsy. Spastic cerebral palsy is most common type. Hyperreflexia, hypertonia, and equinovarus deformity. Feet pointing down and inward, like this is they are looking like the feet of a horse. So that is called as equinovarus deformity. Commando crawl. A child pulls itself with arms while dragging the legs behind. Is often seen due to the contracture of the lower limbs. Brain MRI shows periventricular leukomalacia and the basal ganglia lesions. Cerebral palsy, the risk factors are prematurity and low birth weight. The clinical features include delayed motor milestones, abnormal tone and hyperreflexia, comorbid seizures like intellectual disability. Diagnostic workup include MRI of the brain with or without electroencephalography, with or without genetic metabolic testing. Management is physical, occupational speech therapies, nutritional support, and anti-spastic medications. Prematurity with less than 37-week gestation is a greatest risk factor for cerebral palsy. Cerebral palsy in premature infants is associated with a periventricular leukomalacia, white matter necrosis from ischemia, and intraventricular hemorrhage, germinal matrix bleeding due to the fragile vasculature can also occur. So, haven't we done that? MRI of the brain. Okay, that's again from UWorld but a different table. So, this is the latest table. The risk factors are prematurity, low birth weight, intrauterine infection, perinatal complications like placental abruption or hypoxic ischemic injury or stroke. The clinical features include spastic, which are the most common, affect one or more limbs. Spastic diplegia affects bilateral lower extremities. Hemiplegia affects unilateral arm, leg, and quadriplegia affect all extremities. So it affects one or more limbs. Hypertonia may have hypotonia initially, motor delay, commando crawling, that is diplegia, early hand preference, hemiplegia, contractures, dyskinetic, for example, chorioarthrotic or dystonic, involuntary movements and dysarthria, ataxic, which means hypotonia in coordination and jerky speech. Diagnosis typically established by the age of 2 years, associated with the foot deformities like talipes equinovarus or clubfoot. So this is underdeveloped calf, fixed plantar flexion like this one, and forefoot adduction and inward facing sole. Okay, so this is talipes equinovarus or club foot. Now let's talk about cephalohematoma. Hyperbilirubin. What does that even mean? Cephalohematoma, it is subperiosteal hemorrhage. The clinical features include firm, non-tender. The cephalohematoma is this one, this thing. Remember, it is nothing to do with the meninges or meningeal hemorrhages which are down below that. It is above the skull. That is why it is cephalohematoma. So it is firm, non-tender, does not cross the suture lines, and no skin discoloration is present. Most cases resolve spontaneously. So the types of cranial hematoma, number one is caput succedaneum. Caput succedaneum. Okay. Then we have cephalohematoma, which we are going to discuss right now. Then we have epidural hematoma caused by the middle meningeal artery rupture. There can be subdural hematoma caused by the rupture of the bridging veins. And subarachnoid hematoma is not mentioned here. And this is scalp. If the bleeding is within the scalp, it is called caput secundaneum. If it is below the scalp, like below the glia aponeurosis, then it is called cephalohematoma. And then we have the periosteum and a lot of other things which are not concerned right now. So subglial hemorrhage, right? The cephalohematoma. No. Yes. Okay, I'm sorry. The cephalohematoma is subperiosteal hemorrhage. Like it is just below the periosteum. I'm sorry. This is periosteum. So if the bleeding is below the periosteum, it is called as cephalohematoma. Got it. And if the bleeding is subglial, that is a dangerous one. It is caused by very subglial hemorrhage. I think this is subglial hemorrhage. This one. So it is caused by the rupture of emissary veins upon the scalp traction during the delivery. It can lead to massive blood accumulation between the periosteum and the glia aponeurosis. Physical examination shows diffuse fluctuant scalp swelling that extends beyond the suture lines and potentially beyond the skull to the neck. The swelling shifts with movements, expands over 2 to 3 days. Complications include hypovolemic shock, DIC, and death. Okay. Treatment in these cases is supportive treatment. We do the volume resuscitation and correction of coagulopathy. Then there is non-accidental trauma or child abuse. So non-accidental trauma, the risk factors are unstable family situation, vague history, and injury inconsistent with the developmental stages. The clinical features: bruises, fractures at the various stages of healing, femur fractures in non-ambulatory infant, like the child does not even crawl and he is having femur fractures. Posterior rib fractures, which can occur when an abuser is holding the child. Then metaphyseal corner fracture, retinal and subdural hemorrhages, which can result from shaking the baby like very severely. Management is skeletal survey, CT scan of the head, and fundoscopic examination. Basilar skull fracture, it is very dangerous. So the basilar skull fracture can be of these types. Let me zoom it in a bit. So this is anterior fracture, this is a longitudinal fracture, and this one is transverse fracture. Like this is longitudinal and this is transverse. So there can be cerebrospinal fluid otorrhea, CSF otorrhea or CSF rhinorrhea can be present. Periorbital hematomas, like these are the raccoon eyes, and here we have a battle sign, that is mastoid or post-auricular ecchymosis over here. Sudden infant death syndrome, SIDS. So manifestation, okay. Let me zoom it in if I can. Okay, it is clear. So sudden infant death syndrome or SIDS definition. It is sudden unexplained death in the child age less than 12 months. Epidemiology. Peak age is 2 to 4 months. I have to. Yep. So key risk factors are smoke exposure, prenatal or postnatal, prematurity, and prone sleep position. Smoke exposure is an important one. Prenatal and postnatal smoke exposure, prematurity, and prone sleep position. Diagnosis: inconclusive death seen in investigation and autopsy. Consider alternative cause like abuse or metabolic disorder first if red flag is present. Prevention: avoidance of smoke exposure, sleep environment, supine position, firm flat surface with no loose beddings, room sharing, no bed sharing, and pacifier use. Age less than 6 months, history of recurrent apneic or cyanotic episodes, previous SIDS death in the family. So what are that? So these are red flags. So if there is a history of previous SIDS, don't suspect anything else before going to SIDS. So sudden infant death syndrome. Maternal factors, there are like maternal factors like smoking during or after the pregnancy, maternal age less than 20, inconsistent prenatal care. So it can be prevented by a smoke avoidance during and after the pregnancy and routine prenatal care. Infant factors include prone side sleep position, soft sleep surface like loose bedding, bed sharing, prematurity, siblings with SIDS. So prevention is by supine sleep position, firm sleep surface, room sharing, and pacifier use. So what is this? Ring enhancing lesions can look something like this and like this. Okay. Manifestations of intracerebral tumors. So manifestation of central nervous system tumors by location. If they are subtentorial mean that they're they are just below tentorium cerebelli. So there will be increased intracranial pressure and seizures. In most of the children, they are subtentorial tumors. Yes. Posterior fossa, increased intracranial pressure, ataxia, and clumsiness. Brainstem cause ataxia, clumsiness, and cranial nerve palsies. And spinal cord tumors can cause back pain, weakness, and abnormal gait. Pediatric tumor location. So astrocytoma can occur in the cerebral hemisphere. Pineloma can occur over here or in the pineal gland just behind the midbrain. Optic glioma can occur in the optic chiasm or optic nerve. These are subtentorial tumors. Most of them are infratentorial like medulloblastoma, cerebellar astrocytoma, infratentorial ependymoma, brainstem glioma, craniopharyngiomas, and infratentorial posterior fossa. So cerebral vermis, most common malignant child brain tumor. Got it. Then we have medulloblastoma. So I'm sorry, there was an interruption. So the next topic is medulloblastoma. It occurs in the cerebellar vermis. Hence, it leads to truncal ataxia because cerebellum is responsible for the uh, balance of the body and posture of the body. So it can lead to truncal ataxia. Pilocytic astrocytoma. Pilocytic astrocytoma occurs in lateral cerebellar hemispheres, unlike medulloblastoma. So if I draw a cerebellum over here, it looks something like this and like this. And here we have the follicular nodular lobe, and the central part is called as vermis. So the medulloblastoma occurs in the vermis, and if we could see the homunculus of the body, so that is like suppose this is the head, this is the trunk, and the limbs are like in the lateral part of the hemispheres. So if any problem is in the vermis, there will be truncal ataxia, and if there is any problem in the lateral part of the hemisphere, so that will result in problem with the limbs. Like in the pilocytic astrocytoma, which is mostly located in the lateral cerebellar hemispheres, it can lead to dysdiadochokinesia, dysmetria, and intention tremors. Fourth ventricle is close to the cerebellum. Hence, medulloblastoma can also cause obstructive hydrocephalus. So since the fourth ventricle is close to the cerebellum, exactly like it is just uh, underneath the cerebellum, so that is how it can cause uh, obstructive hydrocephalus. Obstructive hydrocephalus is the one in which the uh, ventricular system is not connecting with the CSF, with the subarachnoid space, with the CSF in the subarachnoid space, because you know that the ventricular system is connected with the subarachnoid system. So if there is obstruction between the two systems, then we call it obstructive hydrocephalus. This leads to increased intracranial pressure, which causes headache, papilledema, and vomiting. What is medulloblastoma? Epidemiology. Most common malignant pediatric brain tumor. It's a posterior fossa tumor, originates in the cerebellum, often compresses the fourth ventricle. Clinical features are cerebellar dysfunction. There will be truncal or gate ataxia because of cerebellar vermis involvement. There will be dysmetria, intention tremor, cerebellar hemispheres, obstructive hydrocephalus, which will show as an increase in intracranial pressure, headache, vomiting, papilledema, and abducens nerve palsy. For dysmetria, you must know the finger nodes test will show a lack of coordination of movement, and abducens nerve palsy, because the abducens nerve is like CN6, so the lateral rectus won't be performing normally, resulting in an inability to abduct, and horizontal diplopia will be there. Treatment. The treatment is resection, craniospinal radiation, and chemotherapy. So truncal ataxia, the lesion's location is the vermis, that is the paliocerebellar system. Disturbance of equilibrium. There will be unsteadiness on standing, walking, sitting, that is called as truncal ataxia. Gait is broad based, as you can see the feet are wide apart, and reeling, and eye closure does not affect the balance. So there is a test that is called the Romberg test. If the person is having problem with the proprioception, that is dorsal column system, so the Romberg test will be positive. In Romberg test, the person is asked to stand with his eyes open, and then with, he's asked to walk in the straight line. He can walk, but as soon as the person closes his eyes, the person falls on either side, right? That is positive Romberg test, which is seen in the dorsal column lesions. But in contrast to that, if the person is having cerebellar lesion, the closure or opening of the eyes will do no good to the patient, and the person will have a generalized ataxia in both the situations. Then the next thing is about the choroid plexus papilloma. So choroid plexus is basically a filtering system, you may say. Like it is a filtering net that is formed by the ependymal cells and the endothelial cells of the capillaries, which is responsible for the production of CSF, and that is formed in the ventricular systems. To be very specific, that is being formed in the lateral ventricles. Yeah, so but it can be present in any ventricular system, like in all the four ventricles. So this is choroid plexus papilloma. Like the problem with that plexus, the tumor of that plexus will form papilloma, and thus ventricles will be enlarged. So they are saying that choroid plexus normally produces CSF. Choroid plexus papilloma leads to increased production of CSF. The presentation is hydrocephalus, that is enlarging head. Yeah, because, and it will be, I think, non-communicating hydrocephalus, because the papilloma will be obstructing either of the ventricular system, and the and that ventricle will be enlarging and something. So hydrocephalus, enlarging head, signs of increased intracranial pressure, that is bulging fontanelle, vomiting on walking, and poor feeding. Developmental delay in the infants will also be seen. Headaches in other children, headaches in older children or adults will also be seen, like if it develops later in life. Diagnosis is done on the ultrasound. Ultrasound shows enlarged ventricles. MRI is confirmatory. Treatment is dissection of the tumor. The next point is about the just give me a second. So then we have the craniopharyngioma. The craniopharyngiomas are the ectodermal Rathke's pouch remnant. So basically, the craniopharyngioma is a tumor of the Rathke's pouch remnant. Now the problem with the normal development pathways, it's not how it looks embryologically, just to make a concept. Let's suppose this is the oropharynx, and here we have the pituitary gland. The posterior lobe of the pituitary is neurohypophysis, and that comes from the brain tissue, like the neuroectoderm. But the anterior pituitary comes from an outpouching of the oropharynx, which is called as a Rathke's pouch. Rathke's pouch becomes anterior hypophysis, and then it involutes. But if it remains in any child, so that is a remnant of the Rathke's pouch, which can develop a tumor, and that tumor is called as craniopharyngioma. It occurs in the supracellular region adjacent to the optic chiasm. Compression of optic chiasm leads to bitemporal hemianopsia. It is very characteristic lesion. Pituitary stalk leads to endocrinopathies, which will present as growth hormone deficiency and diabetes insipidus. It can present with headache or obstructive hydrocephalus. Calcification is classic, as you can see in this picture, that this very white lesion is a calcified uh, craniopharyngioma. Then we have craniopharyngioma epidemiology. It is benign and slow growing, derived from remnants of Rathke's pouch. There is a bimodal age distribution, like initially it is pediatric, 5 to 14 years of age, and then it is also seen in the elderly population from 50 to 75 years of age. Clinical presentation: optic chiasm compression will result in bitemporal hemianopsia. Pituitary stalk compression will lead to endocrinopathies. Growth failure in children, decreased TSH and decreased growth hormone. Pubertal delay in the children or sexual dysfunction in the adults, that is decreased luteinizing hormone and FSH. Diabetes insipidus will happen, that is decreased ADH production. Diagnosis: MRI and CT scan will show calcified or cystic supracellular mass. Surgical resection with or without radiation therapy will also be seen. So there is antidiuretic hormone, FSH, follicle stimulating hormone, growth hormone, blah 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 blah. The next thing is about the pineal gland tumor. So pineal gland tumor, the clinical features of the pineal gland masses. There are two classical features. The first one is Perry-Nord syndrome, dorsal midbrain syndrome. Why so? Because suppose this is the midbrain, something like this. So the pineal gland is situated right over here. So if there is any tumor, it can compress the dorsal midbrain as well. So that is why it can cause Perry-Nord syndrome and obstructive hydrocephalus. So the clinical features of pineal gland is Perry-Nord syndrome, limited upward gaze will be seen. Okay, upper eyelid retraction, which is called as the Collier's sign, and pupils non-reactive to light and reactive to accommodation. It is seen with the Perry-Nord also. What? Paranoid also. I don't know what does that mean, but Perry-Nord syndrome is basically the limited upward gaze is present in these people. Then obstructive hydrocephalus, because it can obstruct the cerebral aqueduct of Sylvius, which is connecting the third ventricle with the fourth ventricle. So the people can have papilledema, headache, vomiting, and ataxia. Pineal gland location is a quadrigeminal cistern. Function is melatonin production, which is basically regulating the sleep-wake cycle. Complication from the mass effect is Perry-Nord syndrome, and obstructive hydrocephalus can block the flow from aqueduct of Sylvius. Trilateral retinoblastoma. Trilateral retinoblastoma contains bilateral retinoblastoma with a pineal gland tumor. So there is a thing that we call trilateral retinoblastoma, and that trilateral retinoblastoma contains bilateral retinoblastoma with a pineal gland tumor. Okay, so this is a cross section of a brain for some reason. Like this thing is called the corpus callosum. Then over here we have this septum pellucidum. Then somewhere no this is septum pellucidum, and this was fornix. Now here we have the anterior commissure. This is hypothalamus. Then these are the mammillary bodies. Brainstem include the midbrain. This is midbrain, and this is midbrain. Between them is the cerebral aqueduct of Sylvius. Yeah, that is passing through the midbrain. Then this thing is called the pons. Here we have the medulla oblongata. This is cerebellum. The fourth ventricle is like this rhomboid structure over here, like this one. Fourth ventricle. Then we have calcarine sulcus. This thing is the calcarine sulcus. This is a parieto-occipital sulcus, which is separating the parietal lobe from the occipital lobe. The pineal gland is situated right behind, or you may say, yeah, right behind the midbrain. Like the midbrain is like this, and it is situated over here. And then we have the thalamus. This thing is thalamus and the choroid plexus, which is present in this ventricular floor or roof, whatever you may call it. Then we have traumatic carotid injuries. Now, carotid means carotid arteries, so they can be very devastating. The traumatic carotid injuries can be caused by penetrating trauma, fall from the object in mouth, that is toothbrush or pencil, neck manipulation, for example, yoga or maybe sports, presentation, gradual onset hemiplegia, okay, aphasia, neck pain, and thunderclap headache, similar to subarachnoid headache. Actually, I didn't get it. They are talking about carotid arteries, maybe, most probably yes. So gradual onset hemiplegia, there can be aphasia, neck pain, and thunderclap headache, similar to subarachnoid headache. Diagnosis is done by the CT or MR angiography. Here you can see penetrating or blunt posterior pharyngeal trauma. So by a toothbrush or something, there can be tearing in the tunica intima, which results in arterial dissection. And if that happens, so it can be very, very troublesome. Neck manipulation, for example, sports, cryopractic manipulation. So even that can lead to tearing of the tunica intima that can result in artery dissection at a level of C1, C2, and C3. Okay. Then the next thing is about the bacterial meningitis in children in age more than 1 month. The bacterial meningitis clinical features are fever, increased intracranial pressure, for example, headache, vomiting, and altered mental status, meningeal irritation like mucorigidity. Workup is complete blood count, blood cultures, lumbar puncture for the cerebrospinal fluid analysis. Treatment is intravenous vancomycin and ceftriaxone or cefotaxime. Dexamethasone for Haemophilus influenza type B meningitis can also be given. Complications include intellectual and behavioral disabilities, hearing loss, cerebral palsy, and epilepsy. Intravenous vancomycin and ceftriaxone, they displace the bilirubin from the protein, increase bilirubin, but somehow that is safe in children. Okay, that was not about vancomycin, that was about ceftriaxone only. Then we have sensory neural hearing loss after the bacterial meningitis. This complication is most common after the Streptococcus pneumonia meningitis, infection or inflammation of the cranial nerve 8, cochlea, and labyrinth. Regardless of the organism, all the patients with the bacterial meningitis should undergo audiologic testing. Okay. Risk factors for complications of bacterial meningitis include younger age, delayed time to treatment, prolonged seizures, high bacterial load, low CSF glucose at the time of diagnosis. All of these things are risk factors for complications of bacterial meningitis. Next one is about HSV encephalitis. So the clinical findings include fever, headache, seizures, altered mental status like confusion and agitation, focal neurological findings like hemiparesis, cranial nerve palsy, and ataxia. Diagnostic findings include CSF analysis with an increase in WBCs and increased lymphocytes, increased RBCs, increased proteins and normal glucose, HSV DNA on PCR, brain MRI will show temporal lobe hemorrhage and edema. Treatment is intravenous acyclovir. This RBC thing is very important and peculiar about the HSV encephalitis. Then we have sudden infant death syndrome. We have talked about that before, but let's see this table again. So definition is sudden unexplained death of a child aged less than 12 months. Epidemiology is peak age is 2 to 4 months. Key risk factors include smoke exposure, prenatal or postnatal, prematurity, prone sleep position. Diagnosis, inconclusive death scene investigation and autopsy. Consider alternate cause, for example, abuse or metabolic disease if red flag symptoms are present. If red flags are present. Red flags means age less than 6 months, history of recurrent apneic or cyanotic episodes, previous SIDS death in the family. Prevention, avoidance of smoke exposure, sleep environment, supine position, firm flat surface with no loose beddings, room sharing, no bed sharing, and pacifier use. Then we have mastoiditis. It is a condition in which the mastoid process of the, I don't know which bone it is, I think it is temporal bone, but the mastoid antrum has some sort of inflammation. The mastoid air cells undergo inflammation. That is called as mastoiditis. It can be very benign or very, it can be a benign condition, but it can become very hazardous as well. Causative organism is Streptococcus pneumonia. strep pyogenes, Staphylococcus aureus, and Pseudomonas aeruginosa. In the patient with recurrent infection or recent antibiotic use, it is commonly seen in the children aged less than 2 years. Mastocytitis, the pathophysiology. It is a complication of acute otitis media, most commonly due to the Streptococcus pneumonia. Strep pneumo is going to cause the MOPS. MOPS means meningitis, otitis media, pneumonia, and sinusitis, and it is the number one cause of all of these organisms, all of these pathologies. Clinical finding: fever and otalgia. Otalgia means ear pain, inflammation of the mastoid, deviation of the ear, opacification of the mastoid ear cell on the CT scan or MRI. Management: intravenous antibiotics, drainage of the purulent material. Complications: extracranial extension, that is subperiosteal abscess, facial nerve palsy, hearing loss and labyrinthitis, intracranial extension, brain abscess and meningitis, inflammation of the inner ear or the nerves that connect the inner ear to the brain. Okay. Then the next thing is about the lesions on the face. Common vascular lesion in childhood. The first one is nevus flammeus, port wine stain that we see in the Sturge-Weber syndrome. Then can be nevus simplex and hemangioma. That is also called as strawberry hemangioma in the kids, and if it is in adults, we call it cherry hemangioma. So red to purple patches that do not regress, and they respect the midline. They always stay in the midline. The nevus simplex, blanching pink patches that fade with time, usually located on the eyelids, glabella, and nape of the neck. They simply go away. And hemangiomas, they are bright red, raised black, undergo proliferation, followed by involution. Then the next thing is about the fetal Hayden-Toyne syndrome. That is characterized by fetal Hayden-Toyne syndrome is characterized by the fetal Hayden-Toyne syndrome. There is microcephaly, there is cleft lip and palate, cardiac defects, hypoplasia of the nails and phalanges. That is very classic in the fetal Hayden-Toyne syndrome. Fetal Hayden-Toyne syndrome is a characteristic pattern of mental and physical birth defects that result from maternal use of anti-seizures, anticonvulsant drugs, phenytoin. So that is fetal Hayden-Toyne syndrome. The name is similar. Dilantin during pregnancy. Similar to fetal alcohol microcephaly. The microcephaly is similar to the fetal alcohol syndrome, but the rest of the things are not very similar. Yeah. So fetal Hayden-Toyne syndrome is caused by the phenytoin, and that include microcephaly, cleft lip and palate, cardiac defects, and hypoplasia of the nails and phalanges. Now let's talk about myelomeningocele. Pathophysiology of myelomeningocele: the most common neural tube defect, failure of neural tube closure, protrusion of the meninges, cerebrospinal fluid, and spinal cord through the skin, increased risk with a maternal folate deficiency. Clinical features: membranous sac over the lumbosacral region, severe neurological deficit distal to the lesion like paralysis, bowel, bladder incontinence. Associated abnormalities include cardiac malformations, inferior displacement of the medulla and cerebellum through the foramen magnum, and obstructive hydrocephalus. Carry 1 malformation associated with the syringomyelia. Common dermatologic manifestation of closed spinal disc rhaphism, spina bifida occulta. So there are common dermatologic manifestations of spina bifida occulta, which is also called as closed spinal disc rhaphism. It can be dimple more than 5 millimeter long and more than 2.5 centimeter above the anus, like here. It can be a hair tuft, as you can see in this picture, hemangioma like this, and subcutaneous mass, for example, lipoma. So spinal process defect, like the spinal process is not present and nothing is protruding out. The dermatologic manifestation can look something like this. Then the next thing is about the Kallmann syndrome. GnRH does not come down from the olfactory placode and no smell or fertility. So Kallmann syndrome is characteristic that there is neither there is anosmia and hypogonadism. The people are infertile. So Kallmann syndrome for the male, there will be anosmia, hyposmia, small phallus and testicle, no body hair, and no pubic hair. Also, I think that try to write also. No breast development in the girls, and there will be primary amenorrhea along with anosmia. So what is Perinaute syndrome? We have talked about that before. So Perinaute syndrome is a condition that affects your eyes' ability to move up and down. pressure on the pretectal region of the midbrain that can be caused by a pinealoma, which leads to bilateral eyelid retraction. I don't know what was the name. I think it was Cooley's sign or something. Um, just give me a second. I think that was Cooley's sign. No, that is Collier's sign. Just yeah, this one is Collier's sign. The next thing is so there can be Collier sign, which is also which is basically the retraction of the eyelid, downward gaze preference, and light near dissociation. It is associated with the pineal tumors. Normal downward gaze, problem with the upward, and there will be eyelid retraction as well. So paranoid dorsal midbrain syndrome, supranuclear up gaze palsy, there will be normal downward gaze. Large people with light near dissociation. The pupil will not be able to do the convergence, but they will react to the light. Late retraction, Collier sign, and convergence retraction, nystagmus will be there. In children, aqueduct stenosis, meningitis, and pinealoma can cause it. In young adults, demyelination, trauma, and AV malformations. And in elderly, vascular accidents and posterior foci aneurysms. Osler-Weber AV malformations can be a cause of paranoid syndrome in the adults. So this was all about CNS, and from the next session we'll start the CVS. Until next time, Allah Hafiz, Fi Manillah, and take care.